Okay. Why the presentation? Okay, now we have a presentation. Okay, so let me just, in a few words, just talk about Tel Aviv University so you know where we came from. First of all, Israel is a small nation in terms of population and size of the country itself. We are only 8 million people, so it's like a large, maybe even medium-sized city in Asia. And for that, Tel Aviv University is considered quite big because we have 30,000 students, 9 faculties, over 125 schools and departments. We ranked number 20 in the World Citations Index. Now you can hear me better? Okay. Tel Aviv University is ranked number 20 in the index of academic citations and about top 100 universities internationally in most international grades. Inside Tel Aviv University, we have the medical faculty, and inside the medical faculty, we have the dental school. The dental school is not a faculty by itself; it's a school inside the medical. It belongs to the medical faculty. And I would like to start by saying, talking about a little bit about my department, the Odontic department, and specifically about the programs of the graduate programs. Okay, we have, of course, we have our teaching of undergrad students, but I would like to focus now on the graduate program. Our program is 3 years full program. Of these 3 years, 2 years are in our department, and I have another 6 months of doing basic research and another 6 months of rotations in oral surgery and another rotation they can choose by themselves. Currently, I have 14 residents, 18 faculty members, and we have like 8 clinics, fully equipped clinics. And let's go to talk about our research. Now, I'm not gonna talk about all the studies that we are doing in Tel Aviv. I just wanna give you guys a little brief of a few of them so you can get the sense of what we do. And we'll start with a few basic research studies. This is from a recent published study that we just published a few months ago. You can all see the title of it. We assess the products of probiotic bacteria as a way to treat persistent infections. Probably all of you knows what probiotic bacteria means. In order for a bacteria to be called probiotic bacteria, it has to have 2 requirements. One of this is that it will not cause a disease in the host, and the other one that it can kill other bacteria. This makes it a probiotic bacteria. And probiotic bacteria are used commonly in food industry and all over. So I think it's for the first time we use it in endodontics. Our enemy, I can call it an enemy, or the main bacteria in endodontics, you probably all know and heard about Enterococcus faecalis. He's considered to be our pathogen of persistent infections. And we would like to, and our common ways to treat it by sodium hypochlorite irrigations and other methods of irrigation usually end up with persistent infections. It always stays there. Sometimes it can cause another disease, a persistent disease, and sometimes it will not cause a disease, but it's usually there. And one of the things we wanted to see is not the way just to kill it, but also to prevent its regrowth, which is usually the problem of persistent infections. So we exposed bacteria first to sodium hypochlorite. This is what we do in the clinic. And then we evaluate the effect, not even of this directly of the bacteria, of the probiotic bacteria, but only of their secreted products. And as you can see, I will not go into detail into the protocol, but we found a few interesting things. First of all, different concentrations of sodium hypochlorite inhibited the biofilm formation of E. faecalis. This is the way we know what happens, but it didn't eradicate pre-established biofilm. So it's like in real life, when you have already a biofilm that is established, it's very difficult to eradicate it. And the problem is, of course, with sodium hypochlorite, especially in the lower concentrations of 1%, 2%, okay? In the second stage, we tried to use L-Kazai, which is an example of a probiotic bacteria. We tried to use it and see if it can prevent the regrowth of E. faecalis that was previously treated by sodium hypochlorite. As you can see in the graphs, it prevented the regrowth in all levels of sodium hypochlorite irrigations, even in 1%. Then we studied a few types of probiotic bacteria, and we got the same results. Okay, the effect of secreted products of any type of probiotic bacteria that we studied affected the biofilm and the planktonic bacteria of E. faecalis. So we concluded from the study, it's a very complex study, and we have a lot of graphs there, so I tried just to show you a brief of it because it's not the focus of our presentation today. But we saw a few things. First, we saw that a lower concentration of sodium hypochlorite will cause persistent E. faecalis biofilm. Okay. On the other hand, let's say about thinking out of the box, which is a good idea in studying research. Using probiotic bacteria can be a new reservoir of optional therapies to treat those kind of persistent infections. And this study was only the beginning. Now we are working about in other bacteria in different concentrations, combinations with other drugs, for example. So to get to a state that we can improve treatment efficacy. Okay, so this is the first example. Another example of a study, I'm jumping now to another study, okay? The next study, by the way, is one of the collaborators is Professor Nimkovsky. He also joined this project. This is a project that I do in Tel Aviv. As part of my position, I also have a position in Nanoscience and Nanotechnology Center in Tel Aviv. This is a different faculty in Tel Aviv. And we have a collaboration with a lab in the United States in Chicago. And we assess the use of nanoparticles to target the delivery of drugs to inflamed tissues. It can be diabetic tissues, it can be oral tissues. And our goal is to develop novel strategies for the targeted delivery and accumulation of drug-binding nanoparticles to inflamed oral tissues. So just in a few words, these nanoparticles you can load drugs on it. I call it pizza delivery, okay? These nanoparticles can target a specific tissue that is currently inflamed and can be absorbed there and can be accumulated there and can release the drugs there, okay? There is a lot of chemistry behind it and I can't get into details right now, but this is the technology. And we assessed it first to target the delivery of nanoparticles to wounded and inflamed tissues in rats. Of course, we are still in the stage of animal studies. Then we started to assess how we can target specific anti-inflammatory drugs. Okay, let's see what we did. So we did it in a few models, and I'm showing 3 of them. We did it in a pulp. On the left, you can see the pulp exposure rat model, which means that you expose, you drill a hole in a rat's tooth, you expose it, and you leave it open, and then you get an apical abscess. Okay, and then you can target the delivery of the drugs to there. By the way, when I say targeted drug delivery, I mean that you don't give the drug or the vehicle with the drug at the site of inflammation. You give it IV or you inject it in somewhere nearby, but not in the area of the infection, okay? The second model was a alveolar ridge wound rat model, which actually mimics a wound healing process in the oral tissue. And the most interesting model that we use is on the right. We use the Calvarian incision in diabetic rat model, and I will talk about it even a little bit more ahead. So this is what we found when we tried to target the accumulation of these particles in the oral tissues, inflamed oral tissues. We injected it IV, we injected it in buccal infiltration. And on the right, you can see a whole body fluorescence these particles accumulated for a long period at the area of inflammation, okay? Then we used, this is the third and the most interesting model. You know, in diabetes, one of the problems in diabetes is that you have difficulties of wound healing and problems of consistent infections and they are always used on top of inflammation. So we said, let's take diabetic rats. So we induced diabetes in rats and we caused them and we implanted a collagen membrane underneath their, as you can see here, in their calvaria, underneath the periosteum. And the absorption of this membrane, this is an absorbable membrane, corresponds to the level of inflammation. So when you have more inflammation in the site, the collagen membrane will be absorbed faster. And the collagen membrane was marked, so we can follow up and see the absorption of it, okay? So this is what we did. And then we injected the drug, the vehicle, with an anti-inflammatory drug, not at the site, as you can see, not at the site of where the membrane is, but just nearby. And here you can see the in vivo fluorescence imaging, and you can see on the top 3 pictures, you can see that the anti-inflammatory alone, without our nanoparticle vehicle, was not absorbed and was not carried out to the area totally. And on the lower 3 images, you can see how it was absorbed in the area of inflammation. We also saw, when we assessed it histologically, we saw that the membrane was absorbed a lot less. So when you use the vehicle and the anti-inflammatory. So our conclusion was that our nanoparticles present a promising and effective method to target the delivery of drugs to inflamed tissues, both in healthy and diabetic patients. But of course, we are still on the animal stage of studies. So, but our promising results we would like to use it to raise now bigger grants than we had, because our previous grant was planned to be used only for animal studies. And now we want to go ahead to the next step, to do more animals, to do safety studies, for example, and then we can go over to humans. I will go briefly on another study on microbiology. By the way, if anyone has questions, just remember them, and at the end you can all ask me a few questions if you would like. Another study that was recently published is we wanted to trace the invasion of bacterial biofilm into the dental tubes of an inactivated teeth retrofilled with fluorescently labeled retrograde filling materials. Okay, it's always a mystery. Everybody knows that the bacteria in the main canal, root canal. However, how they invade the dental tubuli inside the tooth is more of a mystery, and we wanted to assess it. And we wanted to assess not just where they went, but also their viability, which is 2 different things. So, for example, you can, if you have a viable community inside the dental tubuli, or you have a dead community inside the dental tubuli, it's 2 different things. And we have a model. This study. We have a model that we used several times in the past and published several articles about it. This one we used the same thing. We took extracted roots of human teeth. We cut them, we prepared them, and we retrofilled them with a few retrofilling materials like IRM, MTA, or biodentin. Okay. Then we filled. It was placed in this model, as you can see in the figure. And then we filled it with E. faecalis. Again, E. faecalis is our main bacteria studied, and we filled it from the coronal part for 21 days. And then we took the apical segments and we cut them and made them for preparations. And we labeled both the bacteria and the filling materials. And then we used conofocal to assess it. And we saw a few interesting things. First of all, we saw that the bacteria penetrated more to the buccal-lingual direction, as you can see on the lower left, which actually corresponds to the anatomy of the dental tubula. We know that the tubuli are more sclerotic on the mesial and distal sides. So the bacteria can easily penetrate buccally and lingually. And in this study, we actually saw it for the first time, because in the past we knew it, but we never saw it, okay? We also saw that they penetrated quite deep, okay? There is always a debate how deep they can go. And here we saw that even if the filling can penetrate up to 957 microns, the bacteria can penetrate even a lot more, 1,500 almost, okay? Which is very, very deep. It's almost to the level of the cementum. We also found the effect of the filling material. They play a role there, okay? The biodentin penetrated less, and the associated bacteria penetrated deeper. So there is a correlation between how deep the filling material can penetrate and, of course, how deep the bacteria can penetrate. And also it affects their viability. Deeper filling penetration was associated with shallow bacterial penetration. dead and alive. And we concluded a few things. That even when you have retrograde filling materials, by the way, I know everybody knows, but retrograde filling materials is a model for endodontic surgery, okay? It's not root canal, usual root canal fillings. It's the retro filling that we do during endodontic surgery, apical surgery, okay? So even in the presence of retro filling materials, bacteria do invade deep into the dental tubules. We also saw that deeper filling penetration prevents deeper penetration of the bacteria and adversely affects the viability. So it prevents the invasion, and the penetration community is less viable. And now I would like to show you a few clinical studies that we do. So till now we talked about more of basic research. Now I'll show you a few examples of clinical studies. And the first one I think is one of the interesting ones. Was published again recently, but it was published before in two other studies as well, lesser scale of cases. And we saw that dental implant placement is a possible risk factor for the development of multiple cracks in non-endodontically treated teeth, adjacent teeth. And here you have an example. You have a lower molar with an implant that was placed nearby. And clinically, you can find that it totally cracked, okay? And we saw this in the past, and we published it in the past a few times, but this time we collected a big number of cases. And we wanted to evaluate the potential risk factors to the development of these cracks. So we had more than 200 patients, and interestingly, 34% of them, we could find cracks. By the way, the finding and diagnosing cracks is a tricky thing, okay? First, you need to use a microscope. The protocol, in order for you to see, it's not just any black line you see on the occlusal surface is a crack. So you need to stain the tooth, you need to look with a microscope on it. There are many ways to verify that it actually cracked, okay? So these all cases just came to the clinic for a routine examination. They didn't came with a complaining about a crack. They didn't say they have a crack. The referring dentist did not say it's cracked. But we examined all of these cases, and 34% of them, we found that 80 teeth of them were cracked, okay? 31% of them, this is one from these 80 cases, 41% of these were diagnosed after the placement of adjacent dental implant. So what we can conclude is that implant placement was associated with 10 times higher odds of having multiple cracks in the teeth, okay? And we also saw that amalgam restorations of these teeth played a very significant risk factor for the development of such cases, of such cracks. And I will show you a few examples. For example, this is a case of a lower molar at the time of implant loading, okay? The patient came 24 months later on. He was complaining about caries, but what we saw was also cracked. Okay, so this is an example. So we have all these cases. We could show a clinical examination and radiographic examination from the time of implant placement or loading that it was disease-free, didn't have a crack, and the crack was diagnosed only after a few months, or at least a few months later on. Okay. This is another example. It doesn't have to happen only it can also happen in root canal treated teeth. So for example, we have a lower premolar, and this is the time of implant placement. 20 months later, he came up with a vertical root fracture. Okay, everybody knows vertical root fracture is a fracture of the root itself, not the crown. And you can see it very clearly on the right. And I would like to show you this as definition that in implantology is used all the time. It's called implant protective occlusion. I don't know if you're familiar with it, but mainly it means that you reduce, in order to facilitate the osseointegration of the implant, you reduce the occlusal loads on the implants. But what happens, and it has to happen, is that you increase the loads on the adjacent teeth. So as you can see here on the image on the right, you can see that the implant is almost not in occlusion, and all the forces are applied on the premolar that was later on fractured. And interestingly, the same patient, when you look on the other side, had the same condition. He had the same lower molar, premolar, root canal treated. He had the same implant placed, and 48 months later, he was disease-free, no fracture. And you can see easily from the X-ray that this tooth was submerged, so it's like had no occlusion on it. So what you need to remember is that when you use implant protective occlusion, there is no easy way. If you reduce the loads from one tooth or an implant, you increase it on the other one, on the adjacent one. So you move your money from one pocket to the other. That's what you basically do. And if I would like to summarize this study to conclude it, is that we were able to describe a common profile of a patient with such cracks. It was usually non-endodontically treated premolars that presented with multiple cracks, not just one. They were restored with amalgam, and they were diagnosed with a crack at something like more than 1 year after the placement of several adjacent implants. So this is a common patient profile. And I can promise you one thing that happened to me after I did those studies, that now when you go back to your clinic, you'll see those cases all the time. Because it passed across your eyes till today, but now that you know this type of profiles, you're welcome to send me emails and cases. I'm getting it all the time from people all over the world, because when you see my images here in the studies, you're going to start seeing it on your clinics. Another clinical study, interesting clinical study, and I have just 2 more, and then I'll pass the time to Carlos. I want to talk about a study we did together with our pathology department, that we assessed metaplastic changes in the epithelium of radiculate cysts. Okay, and we had a large series of more than 700 cases. We actually assessed 2 different clinical diagnoses: radiculate cyst or residual radiculate cyst. Residual radiculate cyst, it's a radiculate cyst it was left there after the extraction of the associated tooth. Okay, but it was previously a radiculate cyst. And the metaplastic changes that we wanted to assess were 2. One of them was the presence of mucus-secreting cells, and the other one was the presence of ciliated cells. And we wanted to see any association of these metaplastic changes in the epithelium of the cyst, if it's associated to any type of clinical or radiographic criteria or aspects of these cases. So as we can see here, we had more than 700 cases. Most of them were radiculate cysts, but a few of them were residual radiculate cysts. You can see how histologically a cyst looks like at the right. And we found mucus-secreting cells, 47 cases, almost 7% of them. And we saw that they were more common in residual radiculate cysts, and they were more common in asymptomatic cases. And they usually, when you looked on their X-rays, they were well-defined radiographic borders. And ciliated cysts, cells in the epithelium, we saw in 34 cases, almost 5% of the cases. And what was mostly interesting, that they were highly prevalent in the maxillary molar area. And there are other conclusions for the study, but it was just in a brief. So we conclude that, first of all, it really happens. You can find metaplastic changes in the epithelium of radiculate cyst, and it can be related to the type of the cyst itself, to the clinical symptoms, and to the way it looks like in the radiographic findings, and even to tooth location. And the last type of study that I would like to present, it's called systematic reviews. I hope you all know, familiar with systematic reviews and meta-analysis. This is something that I do a lot in Tel Aviv. Actually, every study that I do, every study, clinical or even basic science studies, I start with a systematic review. The difference between systematic review, I hope everybody knows, and a narrative review, is that a systematic review in a systematic review, you have to ask a specific question and do a systematic literature search and use strict inclusion criteria to find just the literature that is directly related to the specific question that you asked. And you actually consider an original study. And if you have enough data, you have enough original studies that you find, you can also do a meta-analysis of the results, which meaning that you can analyze statistically again the results of the combination of all related studies. Okay? And I took just one example of something that most of you probably use daily in your daily routine, of course in endodontics, but in every other discipline in dentistry. And we assessed the diagnostic efficacy of cone-beam computed tomography in endodontics. Okay? Now, I'll just talking about what diagnostic efficacy means. If I'll ask you guys now what it means, everybody will give me a different answer. So just to give you a background for it. First, all of us know that in order to get to a decision, a medical decision, we need our clinical inspection and we need the diagnostic imaging. And the combination of these two will help us to do decision making. Okay, so we talk about decision making. Now, CBCT is something that we use all the time. And it became like even as a very common diagnostic tool in endodontics. In 2015, we published the first study in endodontics and one of the first studies in dentistry that actually talked about diagnostic efficacy, what it means. Diagnostic efficacy has like a hierarchical model. This hierarchical model was not developed by us. It was developed by radiologists. And it's been used in radiology for more than 20 years, but in dentistry, it has been used just recently. In endodontics, we use it for the first time in 2015. So the level of efficacy, you use it to assess a study, to see what what the study assesses, okay? So if the study assesses the basic level, the technical efficacy, it means the study assessed very technical aspects of the technology. For example, exposure parameter and stuff like that. Has nothing to do with decision making whatsoever. Diagnostic accuracy efficacy, the second level, lower level, would mean that the study assessed the sensitivity and specificity of the diagnostic imaging modality, but it has no relation to decision making whatsoever. You can say if it's accurate or not. Diagnostic thinking efficacy, one more step level, one step higher, it meaning that if the study assesses the effect of the imaging modality on the thinking of the clinical thinking of the dentist. For example, it changed the diagnosis, made an effect on the change of diagnosis. Therapeutic efficacy, it's meaning that the diagnostic imaging affected the treatment. You choose a different treatment, or you choose or a different protocol of treatment. Okay. And the two higher levels, or the highest levels, is if the study affected the outcome. So if you use to assess the effect of using CBCT on the outcome of the treatment, this is considered the highest level, clinical level of diagnostic imaging assessment, okay? And the highest level of societal efficacy is not really relevant in dentistry, which it means how the technology affects the society at all, okay? Implementing the technology in dentistry, for example, how it affects the community. But the 5 lower levels are more relevant. And what we found in 2015, we said that the higher 4 levels are actually affecting the diagnostic, the decision-making and outcome, okay? So these are considered as high efficacy level of diagnostic efficacy, and the 2 lower are considered less. And what we saw is that when we checked all the endodontic literature, and we found hundreds of studies, we saw that only 10% of them actually evaluated the effect of CBCT on the decision-making and outcome in endodontics. 90% of them assessed technical aspects of CBCT, but nothing that really affects how or assess how it affects the way we think or the way we act in our treatments. So in 2015, we concluded that the expected ultimate benefit of CBCT imaging to the endodontics patients is unclear and limited. By the way, this was published in the Journal of Endodontics in 2015. It was very debatable. We had a lot of reactions because, you know, every clinic in the United States has a CBCT machine in the clinic, and when you buy it, you have to use it. And now somebody comes from Israel and says, well, people, I'm not saying it's good or bad. I'm just saying that although you have hundreds of studies, only a few of them, it was actually 6 studies, assess the effect, how it really affects our decision-making. All of the other were very technical. you see a nice image or it's a not nice image. So it was very debatable, and but you know, I have to say for their side that they were very brave to accept it, and until today people are talking about this study. And what we said recently, we said now, last time we looked about all the studies. So now in these days, we decided to focus, to do another search, another systematic review, and just to look all the studies that were published since then, since 2015 till last year, and also to focus on the quality of the higher level studies. Let's say we all know that most studies are assessing lower levels of efficacy, but let's see what the studies that actually assess the higher level of efficacy, let's see their quality. Or in other terms, it calls risk of bias. I don't know if you know the term risk of bias, but when you read a study, for example, I'll give you just a very randomization, okay? If you don't have randomization, a study that assesses the effect of a drug, the risk of bias of your results is very high. Or for example, if you have a clinical study, it's very well planned and you have a randomization and everything, but you have only 2 groups and each group has 8 patients, it's too small. You have a very high risk of bias. So the fact that you have a study that assesses the high level of efficacy of CBCT, for example, how it affects the outcome, doesn't mean that you can learn a lot of it because it may have a high risk of bias. And this is what we wanted to assess. So we did an updated literature systematic search, and we took only the studies that were considered as having high efficacy level and assessed the risk of bias. And this is the usual scheme of a systematic review. It always starts with identification of the higher level, and we identified more than 1,500 studies in endodontics that assessed CBCT. It sounds a lot, isn't it? If I tell somebody who would say, well, CBCT use is very well established in literature. You have more than 1,000 studies, it must be well known. But let's see what is really known, okay? After we did strict inclusion and exclusion criteria, we were left only with 22 studies that actually assessed the high level of efficacy. It's more than 6 that we had in 2015, but it's still only 22, okay? And these 22, we say, well, let's see, we have 22 studies, but let's see what their quality is. Let's assess the risk of bias. And I hope you all guys are familiar with the Cochrane collaboration. Cochrane is like the gold standard for systematic reviews and assessment of risk of bias. And we use their methods for that. As you can see here in the figure, this is a figure from our study. On the left, there is the list of the 22 studies. And on the top, you have the criteria for assessing the risk of bias. And I will not go through all those checkbooks because it's tiring a little bit. But from those 22 included studies, only 2 had low risk of bias. By the way, low is good because it means that it has less risk of bias, okay? Don't be confused. High risk of bias is bad. So 20 of them had high risk of bias, which means that in all endodontics, you have thousands, hundreds, and more than 1,000 studies about CBCT. Only about 20 of them are assessing the way CBCT affects decision-making and outcome. And from those 22 studies, 20 of them has a potential high risk of bias. I'm not saying CBCT is bad or CBCT is good. I can't say it because this is not something that I assessed. I can only say that the literature is not that stable. This is something that we have to know when we use CBCT because CBCT has radiation. Okay, if it was something that has no radiation, we can use it all the time and do whatever we want. But we do affect the health of our patients. So we have to find the balance. And to find the balance of using it correctly and adequately, we have to know that the literature and the science behind it on the way it affects decision-making and outcome in endodontics is quite bad. And by the way, I didn't put it in here, but if you check, there are same systematic reviews also in periodontology, in surgery, and in all the other disciplines in dentistry, and also in orthodontics. You'll always get to the same conclusion. There is no data. There's definitely no data. It doesn't mean it's good or bad. It means that we still have to study and we should still need to be cautious when we use it because it's radiation. And we concluded that the influence of CBCT on decision-making and treatment outcome in orthodontics is associated with high risk of bias. This is the main conclusion that I would like you to remember. I hope I spell it correctly. So I would like to thank you all for listening. We have much more studies in Tel Aviv, but in orthodontics specifically, but this is like a very wide scope of what we do. I'm here later on, so if you guys would like to ask me questions or to talk with me, it's okay. And now I would like to present my friend Carlos Pinkowski. He was, as you know, he's the chair of our periodontology department, and he's gonna talk about updates on periodontal research in our school. Go ahead.
Are there any questions so far that from the audience that you would like to ask right now before I go into different studies? No questions? No questions from the Zoom? Okay.
You know, when there are no questions, there are two options. Either everything was clear or oh, okay. Yes.
Thank you for your excellent talk. I'm interested in the fractures case with the implant support occlusion. Do you have noticed any particular position or area in the mouth that has fractured the most? Because I noticed that most of the picture you show are mandibular too. And we know maxillary and mandibular have different bone architecture. So does it affect? Yeah, or you haven't studied yet?
In general, we all talk about lower second molar, generally in cracks. If you look on cases that are associated with dental implants, I saw it more frequently in premolars. Okay?
Yes.
So there was actually a difference. When it was not associated specifically with an implant, it used to be second molar. When it was associated with an implant, it was usually the implants were placed in the molar region, and the tooth that was cracked was at the premolar region. Yes. So this is a difference, yes.
How about the maxillary and mandible?
We didn't see any difference. In terms of general population, it's usually lower molars. In terms of, because the lower molars has 2 roots. The upper molar had 3 roots. They have better support. There are many reasons for this. But in terms of association with implants, again, it was both arches, maxillary and mandibular, but more cases in the premolars. But anyway, it was 200. 200 sounds like a lot of cases, but you know, the next step would be to collect more and more and more. And we're still collecting. Now we have a few hundred small cases, and we'll probably do another statistics. And probably we may find more risk factors.
Very interesting. Thank you.
Thank
May
you.
I have one more question?
Yeah, sure.
About the systematic reviews that you review. Mm-hmm. So could we say that among the 21 that only study the risk of bias is like maybe from the groups that hate CBCT?
What again? That?
The 20 groups that only study the hierarchical studies. So it's like, it's probably from the group that doesn't like to apply CBCTs in their practice, or we cannot conclude it.
I cannot conclude it. Listen, it's a lot more difficult to do a clinical study that assesses the effect on treatment outcome, for example, because you need to follow up cases for long periods of time and to have follow-ups and everything. It's a lot tougher to arrange. But it's still, you need this data. If you want to answer, if your question is, does it affect the outcome? There is no way around it. You can't show that CBCT show is creating a nice image. It's not enough. It always looks like nice images, but does it affect the outcome? You have, until you really test it on hundreds of cases and you show it, and you do it in a way, in a protocol that has no risk of bias or low risk of bias, your conclusion can be very misleading.
Thank you.
Okay, I have quick question follow from the previous one.
Okay.
Regarding the crack teeth, did you record the technique of implant placement and the brand of the implant and also the crown that you use? Would that matter? Do you think what is the factor, the implant placement itself or the crown, the time that you insert the crown?
I can't say it. This is a question I can't answer. We didn't assess the effect of the type of implant, for example. No. The only thing we did see is that where there were more implants involved, where there were multiple implants, not just one, it did affect. So when there were more implants placed, the higher risk of developing those cracks. But I can't say too much more, but this is another idea for future research, of course. There are many parameters that you can play a role here. It can be, for example, malocclusions or bruxism or any other aspect that you can assess. When you have 200 cases, you can do a big mistake. You can try to analyze everything around everything on 200, and then you'll be ending up with a very high risk of bias because you don't have enough cases. So when you have just a few hundred of cases, you have to focus on your main questions. But all those questions that you ask, when I'll have 500 cases or 600 cases or 1,000 cases, hopefully it will end up, it will happen sometime, then I can do some more statistics and look on the implants and the occlusion and everything. Yeah.
I would like to comment on that. The amount of cases did not allow to see the different brands or something like that. On the second question, whether it was at the time of implant placement, no. We showed, especially Yao, that it was not at the time of implant placement, because at the time of implant placement, there was no crack or fissure. So it was after the implant was rehabilitated. So it has to do something not with the placement itself, but afterwards with the rehabilitation or the protective occlusion that we have a trend to do with the implant-supported rehabilitations.
Yeah, this was the inclusion criteria. If we didn't have enough proof that there was no cracks at the time of implant placement, this case was excluded. Okay, the whole idea was to see that the crack happened after the implant was placed. Yeah. Mm-hmm.
Okay. First of all, I would like to thank you for being here. It's a big pleasure, an honor to be with you. Since Eyal has been here quite a few times and you know him already, well, some of you know him already, I'd like to give a very short introduction of myself. And this is the dental school that you've seen. We have very nice, the Tel Aviv University has lots of green and lots of trees, and it's very, very nice campus. This is how it looked just a few days ago. That's a center of the square, has nothing to do with the dental school, but lots of those trees that in this time of the year, they are very, very full of flowers, and it's very, very nice. And just to give you an idea, this is my PubMed page that was taken a few days ago. We have there 117 results, meaning that 117 of my papers are indexed in PubMed. We have also published together with Eyal 2 books. One evidence-based decision-making in dentistry that has been downloaded more than 11,000 times. This is not an open access, so people have already paid, 11,000 have already paid to read a book. And the last one is endodontic periodontal lesions, also with Eyal and other friends, that since it was later on, it was downloaded only something like 9,000 times. When we go to Google Scholar, my H index in Google Scholar is 47. My papers have been quoted more than 6,000 times around the world. I am right now the editor or guest editor of 2 special issues, one in materials that has an impact factor of 3.7 and one in the Journal of Functional Biomaterials that has an impact factor of almost 5. Now I will go to our department. We have both undergraduate and postgraduate education. In the undergraduate education, evidently, we give the basic and clinical concepts of periodontology and implant dentistry. And the students, undergraduate students, do not perform by themselves periodontal surgery, but they assist on periodontal surgical procedures. They do perform non-surgical treatment and all the other things. If we go to the postgrad program in periodontology, it's a 4-year full-time program where we have 3 years in the Department of Periodontology, and afterwards they have 1-year rotations in 3 departments, 4 months in each. Oral maxillofacial surgery, usually oral rehabilitation. It can also be orthodontics if they prefer. But since we have a very close collaboration with the oral rehabilitation, we do have a joint seminars, and all our cases are together with the oral rehabilitation postgrad students. They usually do the oral rehabilitation rotation, and they must do also oral medicine, oral pathology, and after they have completed this 4 years, they can apply to be a specialist according to the Ministry of Health and pass the examination. And that's a very difficult examination. One is written, and that's the first stage. And if they pass the written examination, they can only go for the oral examination case presentations. Also, all our students must complete a research project. When we go to the research, we do perform in vitro, animal preclinical, and clinical studies. And our main goal of being here is to try to establish a future collaboration with you. So if you see any interest in any of our studies and you'd like to contact us, you have the emails, and or you can join us afterwards. I will go just for an overview, not only of my studies, but of what is being done today in our department. From our research projects in vitro, we have dental implant surface or coatings. What we are doing right now is working together with a metallurgic engineer, trying to see if different types of implant surfaces are similar from the point of view of osseointegration and infection delaying or prevention. And that's very important because we know that rough surface implants are very good for integration, but at the same time, we know that those implants are very bad for periimplantitis. So together with this engineer, he has developed quite a few dental implant surface that we do it on discs that he has prepared together with cells or together with bacteria. And we are right now seeing whether one of those can have on one hand a good osseointegration, and on the same we can find that development of biofilm is reduced. And that is something that could change the face of implant dentistry in the future. We are checking quite a few things concerning periimplantitis treatment. It is being done at this moment with the in vitro, with the implants, trying to treat the implants after they have been contaminated with several procedures and see which procedure gives us the best result. Since this is only in development, I cannot show you data because it has not yet been published. We are working in the characterization of gingival fibroblasts. I will show you some data on that. And we are performing some very nice microbiological assays concerning several issues. We will go to this. isolation of oral mucosa-derived mesenchymal stem cells for tissue and organ regeneration. That's something that we are developing right now. We have just filed a patent on this, and that could be one very interesting field for collaboration maybe in the future. I will go from the beginning. Do we have the sound from the film? Yes? No. No sound? Okay. So you can see it there. The fibroblasts are great potential for advanced regenerative therapies. They regenerate very nice. So, but we have to actually see what we're doing. What we have done, the first stage is to see the differences between the fibroblasts from the keratinized tissue and from the mucosa. And we have seen that they have genetic differences, and that those from the keratinized tissue are much better, have a much larger concentration of progenitor cells than the others. And what we've seen, taking from the same individuals, is that we see a lot of other cells. And what we've been working lately together with one of my colleagues is how to differentiate those cells and isolate those cells by single cell technology, and arrive to that. The first paper has been published in the Journal of Periodontology a few months ago. And the second one, what we're doing is isolating by tissue engineering and then trying to get them for clinical application. So I will not go through the whole story, but we do have to prepare, do the culture, and then go to single cell technology to isolate those progenitor cells, because there are a lot of other cells that we are not interested. And this is our first paper, as I told you, that was published not long ago. And with that, with the single RNA sequencing, what we're doing is trying to isolate those progenitor cells and then bring them to develop, to differentiate into other types of cells. What we are succeeding not bad. As I told you, the isolating system has been just patented, and we're running it very nicely and having very, very nice results with that. And something that is interesting is that we think that the gingival fibroblasts do not differentiate into bone-forming cells. It depends how the cells that you take. Evidently, if you take the whole population, you will see very, very little amount of calcification, because most cells do not. But if you take only those progenitor cells and you treat them accordingly, then we see that we do have a more calcification, and that we can turn and make those cells to differentiate in any type of line cells that we would like to have. At this moment, what we are doing is treating it with a collagen scaffold, planting it, the cells together with the collagen, and implanting it into the rat calvaria and seeing the results. And this is definitely one of the studies. And yes, isolation of stem cells for oral and an organ, for tissue and organ regeneration. When we take it from the different, we take fibroblasts, and we have lots of cells, but we have very, very few stem cells. And we have to identify those stem cells and to isolate those stem cells in order to differentiate them into the different line cells that we want. Because those stem cells, by definition, have regenerative and repair capacities. So we can take those cells that we can identify by genetic screening and then bring them to the area where we want to create the new tissue in the same patient. So we have to identify and isolate those cells. We have to extract them from the mouth. Then we will identify them, the molecules. And then establish the genetic pathway that we need, isolate them, bring them in order to enlarge their numbers. And then we can either bring them for bone forming capacity or soft tissue healing or whatever we need. So this we have already performed, and we have isolated them, and we will have to show the bone forming capacity in wider defects, not in small defects, and to see that our system works every single time. We will apply for large grants for this purpose. Concerning one of the studies that has been performed, this has been just shown in the recent European meeting. The people from my department, I'm not part of this study. They have gone on 3 non-resorbable PTFE membranes. It's an in vitro study and see the different membranes, whether the microbiological pattern is the same in the different, and it is not the same. Different membranes, ePTFE membranes, will behave differently whenever they are contaminated, and the amount of the biofilm that is created is completely different. So this is one of the things that could be in the future developed. In the animal preclinical research project, we are developing novel bone grafts and membranes. I will show you something that we're doing. We are developing dental implant coatings, and we're using also pro-resolvins in collagen membrane resorption. I will show you some of the studies. One of the studies, once again, I am not part of this study, but it's being performed by people from my department. They are using bone regeneration using a resorbable magnesium-based membrane. Magnesium, as you know, is a metal, but it has a bone induction properties. It is very stiff, so it has to be handled very carefully. This is, we're doing CT scan, micro CT scanning with very, very good results, having very good, I will show you some pictures. So what they did, they used the female New Zealand white rabbits, and they created 4 defects. 2 defects were covered. This looks like metal, but this is a magnesium membrane fixed with the screws on one side, and one defect was left empty. The other one was filled with xenograft. And this is with the CT scanning, very nice results that we have of reconstruction. What we have here is what we see here with the screws. And they studied how much bone, how much that space was closed, the amount of bone that was created according to that. And they concluded that this membrane is biocompatible. There was no membrane exposure, that bone graft is required because although it's very stiff, it does not, it's better if we use a bone graft and does not interfere with bone healing. Another one is that they're using a coral xenograft. Evidently, if it's a coral, it is not human. And you can see the kind of reconstruction that they achieve with the micro CT scanning really is very good. It is even better than the histology. Really, when we have good equipment for the micro CT, we achieve excellent results because you can see three-dimensionally and you turn it there. So they have studied the different bone grafts in the same model of the Calvaria, in the rabbit Calvaria, and they have evaluated different methods for CT evaluation, and has been with a very, very good result. We have a master and PhD students working on that, and they're learning a lot. We're using more and more the micro CT than the calcified tissue. We do it afterwards. Concerning the implant modification, implant surface modification, this is a project, it's a multi-European project where we have a group from Italy, another group from Italy, one group from Greece, one group from Romania, and from the Tel Aviv University. We received a funding of approximately €1 million to perform this study from the Euro-Nanomed. And the main thing was to evaluate the antimicrobial nanofunctionalization of a silk fibroin matrix, meaning that we are coating the implants with that and to see whether this enhances osseointegration and or prevents infection, not only in the implant, in dental implants, but also in orthopedic implants. And also the same for periimplantitis. Periodontitis, sorry. Periodontitis is the treatment of periodontitis. We induced periodontitis in the rat model and then treated with the silk fibroin strings that were embedded in antibiotics. So they completely resolve. On the other hand, the antibiotics is released, slowly released. So we have a slow release device that stays there for quite a few days. And on the other hand, we have a slow release device for the antibiotic that we need. Also in the orthopedic implants, also in the dental implants. So we started with the characterization of those fibroin and attachment of the antibiotics, and then coating of the implants or of the strings to put them for periodontitis, and then go to the rabbit model or the rat model for periodontitis, or we did our studies in dental implants in the sheep model. And we have presented that in a recent meeting. We are preparing our final reports, and we've had good results with the orthopedic implants. With the sheep model, we had some technical problems, but results are not bad. We will conclude it very soon. We have right now applied for a grant with 12 other groups, because we're included. also from all over Europe. You can see from Greece, Belgium, Italy, Romania, Belgium, France, Greece, Italy. So we have applied for another grant, much larger, to try to develop nanotechnologies for smart biomaterials, for bone regeneration, once again, not only in dental, but mainly in orthopedic surgery. These bone grafts are novel polymers for biomaterials, non-toxic, low-cost, functionalized, non-organic nanoparticles that we are the development of smart biomaterials, implant devices and scaffolds for classic and rapid prototyping techniques, production of bioinks and synthesis of active nanocoatings for metallic implants. All this is part of this grant. This is the concept that we will not go through, but it's approximately very similar to what I showed you. We will start with the describing, processing, and then trying to bring it into animal studies. One of the studies that we're just concluding is something similar to what Eyal showed you with a similar model. You know that pro-resolving mediators are something natural that can avoid inflammation. So using the same model of diabetic rats, I will go rather fast here. You know, diabetes increases collagenylytic activity. So collagen is degraded much faster. Also collagen membranes, but also any device that you implant in diabetic patients will degrade much faster. And that's a problem because we have lots of collagen devices that are being used. So we want to see where, if we use those pro-resolvins in those collagen devices, we can reduce the resorption of those devices. So pro-resolvins, once again, are the products that are mainly natural, and they slow down inflammatory reactions in diabetic models. So we will just do lyophilization of those membranes with pro-resolvins and take a look at that into a collagen membrane, exactly as Eyal showed you before. We will use two different concentrations of resolvins, and we saw that in a in vitro kinetic study that those pro-resolvins are released from the collagen membranes with or without labeling. We do label the membranes with biotin, and we do a reaction with avidin afterwards. So this labeling does not affect. We did lyophilization. We used resorbable collagen membranes, very well known, and they were labeled or non-labeled to identify where it affects the release of those pro-resolvins. We saw that the higher degree, there's no difference between biotin and not biotin in the two concentrations. The two concentrations, evidently, they release more if the concentration is higher, but there's no difference with and without biotinization. So the model is working, and this is the control. And you can see that in diabetes, we have a much faster degradation of the membrane. What you see in brown is the remaining collagen within the membrane, because we labeled the membrane before we implant it, and whether we place a higher concentration or a lower concentration does make a big difference. But the higher concentration, no doubt, we see almost no degradation of the membrane. So we can use that kind of procedure to use it. We're just right now measuring this biotin avidin labeling allows us to measure exactly the amount of collagen that's within the membrane that we implant. So we can really see it and measure it, but we cannot do it without labeling the membrane. So we do an ROI, region of interest, and we measure it, and we have the different things that we are seeing, also the types of sales and the amount of that, and we measure that. That's the way it is. That's our initial result. The control is what you see with the diabetic. We have a much higher resorption. This is the amount of collagen that remains within the membrane. So with the control and diabetic, there's a significant difference. However, there's no difference between non-diabetic rats and if we use the different concentrations of pro-resolvins. So we are in a good track there. This is something that also could be a very good basis for future collaboration. This is not involved in this study. This is part of my department, evidently, that they have patented a collagenase that eases the tooth extraction. So they inject the collagenase, has no side effects, and then the tooth comes out very, very easily. Because usually we have problems with the impacted teeth, or when we want to place an implant, if we break the bone, when we try to extract it, then we have a problem. So they said, okay, we will try to preserve the bone by injecting a collagenase that dissolves the PDL fibers. And that's what they did. And so far, they have very nice results. They have done it in there's different applications. They have different also applications, non-dental applications, and it works very nicely. They tried it in animals. The patent has been submitted, and they found that it works very, very nicely in animals. And when did the toxicity, they found that it has no side effects with very good results. No breaking of teeth as happens with normal extractions. And that could be a very good result. This is with collagenase, and this is with PBS. Exactly the same cells are not affected. Evidently, when they use ethanol as negative control, everything is dead. So they have a patent application right now. They must do the regulation formulation on in vivo safety and efficacy, and then we can go for human studies. Has been published right now in the Journal of Functional Biomaterials. Clinical research projects, we are in development of a new application for periodontal disease classification. What I will show you right now, people from my department have developed a new application, smartphone application. I gave a few cards. You can just scan the QR and you can download it to your phone. It's free, has no advertisement, no nothing, and actually it eases the way how we talk to the others, because the new classification for periodontal disease is very complicated, and this eases very much. You just have to, in a few seconds, you can achieve the classification. Not only that, it's very easy to communicate with the other dentists because they will do the same. They will take a look and see what happens. We are working a lot, evidently, on implant-supported reconstruction, on periodontal reconstructive treatment. We have published a lot on the effect of Emdogain on periodontal regeneration, and we have published quite a lot of studies on root coverage procedures. I will show you just a few things to be done with that very fast. That's a digital support system, Perioclast, they call it. And just download it and you see that it works very, very nicely. They have validated it. There's no patent on that because you do not patent applications, but it works very, very nicely. And we're very happy. Also for the students, it's something that they can download. Whoever wants can download it, and there's no problem. Another study that has been performed, once again, I'm not part of this study. It's a multidisciplinary study, is to evaluate whether tilted implants have more peri-implantitis than others, than the regular implants, and they did not find any difference. But this is only a real example. They are doing a lot of, if you go to the literature and you write periodontology Tel Aviv, you will see the amount of publications that have appeared lately, and it's like that. I would like to thank you. If you have any questions, I will be more than happy to answer.
Thank you for your presentation. It's very nice. Actually, at the first part is actually my field of study, so that's very interesting. The study that you mentioned about MSC from different location of oral cavity, actually, Dr. Suprita is over there. She did the same, exactly the same experiment as yours. She isolated MSC from like free gingiva, so circular gingiva, and compare it using sequencing. And now I think she sent the manuscript for under review in J Periodontology. Yeah, that may be the way to connect to each other. That's very nice study anyway. You have anything to add for that?
Oh, thank you very much for your amazing lectures. And I'm Suprita from the Department of Periodontology, and I have two questions. First question is about the research that Dr. Thanapu already mentioned. And from your data, the preliminary data, I'm not sure, the single cell RNA sequencing analysis that show that they're kind of a small population of the MSCs from the oral mucosal tissue. And in my concern about the clinical application, I think that it's the same question also in my mind, that the population of MSC is quite small, and for the administration technique of the stem cells must be very critical to enhance the regenerative outcome. So in your opinion, what do you think of what kind of administration of stem cells is really the most suitable for the clinical settings?
That's a question that shows that you're working on that. What we're doing is using the single cell sequencing in order to differentiate those cells, and then we can isolate those cells and then amplify the cells. So actually, from the initial tissue, we have a lot of cells that we can say they're waste, but it's enough that we recognize by a special sequencing that we have just filed a patent on that. But with a special sequencing, we recognize those cells, then we amplify those cells, we bring them to collagen scaffold where we can bring them according to that. So far, we have not performed the animal studies. We have done it in vitro, and we see that we can bring them, for example, to the osteogenic pathway. That's fine, because usually those cells from the gingival fibroblasts do not calcify. But if we bring them to the, so we have shown that, we have seen that we can have also from other pathways, but you know, all those studies are very, very expensive. So preliminary data helps us to apply for a grant. And I'm sure that in 1 or 2 years, we will be in a different stage. But at this time, to tell you exactly how we are going to transfer that to the patients, we do not really know, but it is working. meaning that we can identify those cells, we can extract those cells, and then amplify those cells and bring them to the pathway that we want to bring them. And I cannot tell you more.
Yes, I think it's enough at this level.
Yes.
We have to find out further.
Yes, I'm sure we have just now, just yesterday, or day before yesterday, received the okay from the university that they're going to patent that. So we have prepared already our second paper that will be submitted very soon. I am sure that if the first one was accepted, this one will be also accepted, and you will publish in Perio. We'll see where we publish.
Okay.
But thank you.
Thank you very much, Professor. And
It will be a pleasure to collaborate. It's all right.
Yes, of course. It's very exciting to see your research. And one more thing about the 4-year course of periodontal postgrad student. I would like to know what kind of degree that they will receive after graduation. Is quite a long time in school for 4 years.
They do not receive a real degree because it's only studies that are parallel. They do not do a master. They can do a master, but has nothing to do with the specialization. They do not receive a PhD because it's not a PhD. They can do a PhD if they want, but has nothing to do with that. So actually, they are entitled they are entitled to present themselves for the exams and be as a recognized specialist by the Ministry of Health. But they do not receive a real title from the university because these are not real studies from the university. This is a post-grade study on periodontology. So it's a question of legislation, but they do not receive. I did the same thing few years ago, but I did the same thing. I do not have a master or PhD from there because it has nothing to do. So also in what they did there's one international program in Tel Aviv, that's all in English, that's the orthodontic program. And there's some also people from Thailand were there and did the postgrad. They do a master because it's a clinical master. So they do receive a clinical master in orthodontics. They have to prepare one research project and they have to take several courses, but that's the only one but it's a clinical master. So something that was tailored for that program. But no, it is not a real degree.
Thank you very much, Professor.
Any question from the online people? If you cannot turn on your microphone, you can just type in the chat box. I can read that question for you if you have some.
So I think we don't have any further question. And on behalf of Faculty of Dentistry, Chulalongkorn University, we would like to thank you so much for being here today and sharing your great research work. And we hope that we will have further collaboration between Tel Aviv University and our faculty. Thank you very much for being here today.
Thank you. Looking forward to it.
Thank you.
Thank you for having us. It was a great pleasure, and it's just the beginning. And we are available for everyone. Noom has our details. You can find us and call us anytime.